Let us now consider the blood supply of cerebrum. Although brain weighs only about 2% of the entire body weight, it consumes close to 17% of the cardiac output and 25% of the body's oxygen. Without blood supply to the brain, a person becomes unconscious in about 15 seconds, and there will be permanent damage to the brain in about 5 minutes, which may even end up in the death of the person. This sort of underscores the significance of blood supply to the brain and highlights the dependency of brain on the continuous supply of nutrients as well as oxygen. The main supply of blood to the cerebrum comes from the circle of Willis, named after the famous British neuroscientist Sir Thomas Willis. Now, the circle of Willis is located within the interpeduncular fossa or interpeduncular cistern, which is in the middle portion of the base of the brain along the midline. Now, this establishes connection or communication between the anterior circulatory system with the posterior circulatory system. When I say anterior circulatory system, these are basically the internal carotid arteries and their corresponding branches. When we say posterior circulatory system, it is basically the vertebrobasilar system and their branches. So, the circle of Willis will establish connection between the branches of internal carotid arteries with the branches of basilar artery. So, what we are seeing here is the basilar artery because we are at a higher level. The vertebral arteries of both sides would have joined together to form the basilar artery at the lower level, that is at the pontomedullary junction. Here we are seeing the upper end of the basilar artery. So, let us first check what are the branches coming from these arteries which will take part in the formation of circle of Willis. From the internal carotid arteries, we have anterior cerebral arteries given as the branches. Now, the two-sided anterior cerebral arteries connect with each other through anterior communicating artery. The basilar artery ends at the upper level, upper border of the pons by giving its terminal branches. They are known as posterior cerebral arteries. Another set of branches given by the internal carotid artery, they are known as posterior communicating arteries. They will run backwards to establish communication with the posterior cerebral arteries. So, these are the arteries which will complete the circle of Willis as you are now seeing on the undersurface of the brain. So, circle of Willis is formed by anterior communicating artery anteriorly. Anterolaterally, it is contributed by the anterior cerebral artery. Laterally, it is contributed by the internal carotid artery. Posterolaterally, it is contributed by the posterior communicating artery. And posteriorly, it is contributed by the posterior cerebral artery on either side and basilar artery in the midline. So, this circle of Willis is not only establishing connection between the anterior circulatory system with the posterior circulatory system, it is also establishing connection between the left-sided vessels with the right-sided vessels. Normally, very little blood will be flowing through the circle of Willis, but in case of any obstruction to any one of these arteries, the rest of the arteries will at least take care of the supply partially to the extent possible. Apart from these branches which are forming the circle of Willis, one more branch of the internal carotid artery which I would like to mention here because that is again important in the supply of cerebrum, that is the middle cerebral artery. Now, coming to the branches of circle of Willis, they are grouped depending upon their location as anteromedial branches, anterolateral branches, posteromedial branches and posterolateral branches. All these are perforating branches, so they perforate through the substance of the brain and supply the structures immediately deep within. So, let us start with the anteromedial group of branches. Now, these branches are given by the anterior communicating artery and the anterior cerebral artery. Now, they will supply anterior part of the hypothalamus as well as the subcallosal area which is located on the medial surface of the cerebrum. The second set of arteries are known as anterolateral branches. They are also known as striate branches. These are branches given by anterior cerebral artery and middle cerebral artery. The branches given by the anterior cerebral artery are known as medial striate branches. including the recurrent stride branch known as Heubner's artery. And the branches given by the middle cerebral arteries are mostly lateral stride branches, otherwise known as lenticulostride branches. Few of them, however, can be named as medial stride branches. Now, among the lateral stride branches of middle cerebral artery, one of them is the largest, known as Charcot's artery, and this is also commonly known as artery of cerebral hemorrhage. Now, they are known as stride branches because all these branches will perforate through the anterior perforated substance, and on the deeper aspect they supply corpus striatum as well as internal capsule. Now, third set of branches are the posterior-medial branches. Now, these are also known as thalamo-perforate branches. They are given as branches coming from the posterior communicating artery as well as posterior cerebral artery. They supply diencephalon as well as pituitary gland. When I say diencephalon, they supply thalamus, hypothalamus as well as subthalamus. And the last set of branches are the posterior-lateral branches, also known as thalamo-geniculate branches. These are given from the posterior cerebral artery. They supply the posterior-most part of the thalamus, that is the area in and around pulvinar, including pulvinar, and also it supplies lateral geniculate branch, lateral geniculate body and the medial geniculate body, and few of these branches will also end up supplying anterior part of the midbrain. Circle of Willis shows few variations. One of the branch contributing to the formation of circle of Willis may be absent, but more commonly some of these branches will be hypoplastic. That is what is shown in these pictures here. Here we are seeing hypoplastic anterior communicating artery or the anterior cerebral artery, posterior communicating artery or the posterior cerebral artery. Now, coming to the blood supply of cerebrum, the three main arteries which supply blood supply to the brain cerebrum include the anterior cerebral artery, middle cerebral artery and the posterior cerebral artery. The area supplied by anterior cerebral artery is shown in red color here. Area supplied by the middle cerebral artery is shown in yellow color here, and the area supplied by the posterior cerebral artery is shown in the blue color here. Now, coming to the anterior cerebral artery, this is the artery which supplies predominantly the area on the medial surface of the cerebrum. It includes the medial surface of frontal as well as parietal lobe, including most of the anterior 2/3 or almost anterior 2/3 of the corpus callosum. It also includes frontal pole, anterior part of the orbital part of the inferior surface, and on the superolateral surface it supplies 1 to 2 centimeters area along the superomedial margin, almost reaching the or almost till the area between postcentral gyrus and the parieto-occipital sulcus. Now, coming to the middle cerebral artery, this is the artery which supplies predominantly the superolateral surface. So, it supplies almost 2/3 of the superolateral surface, including the temporal pole and the posterior part of the orbital aspect of inferior surface. Now, this middle cerebral artery, however, does not supply the area adjoining the superomedial border. Now, coming to the posterior cerebral artery, this supplies predominantly almost all the tentorial surface or tentorial aspect of the inferior surface except the temporal pole. On the medial surface, it supplies the posterior part of the medial surface, that is the area behind the parieto-occipital sulcus, including cuneus and lingual gyrus, as well as the occipital pole. Now, on the superolateral surface, it will supply the an area of about 1 to 2 centimeters adjacent to the superomedial margin, most of the occipital lobe, and the entire extent of inferior temporal gyrus except the temporal pole. So, if you see the three poles, the frontal pole is supplied by the anterior cerebral artery, temporal pole is supplied by the middle cerebral artery, and occipital pole is supplied by the posterior cerebral artery. Now, coming to these individual arteries, first let us start with the anterior cerebral artery. It's a branch of internal carotid artery. It takes its origin on the inferior surface where we were seeing the circle of Willis, Soon it will travel towards the medial surface, enters the great longitudinal fissure, and it will arch over the corpus callosum on the medial surface. So depending upon its course, it is divided into 3 segments. A1 segment is from its origin till that point where it will be joined by the anterior communicating artery. A2 segment is distal to its connection with the anterior communicating artery till such point where the callosomarginal artery arises as a branch from it. And the A3 segment is that part of the anterior cerebral artery which is distal to the callosomarginal artery. Now coming to the branches from the anterior cerebral artery, all these cerebral arteries give 2 sets of branches: central branches, or otherwise known as perforating branches, and cortical branches, which will be supplying the surface of the cortex. So central branches from this anterior cerebral artery arise from the A1 segment. They include medial striate branches as well as the recurrent striate branch known as Heubner's artery. Now coming to the cortical branches, they supply the frontal lobe as well as the parietal lobe, especially on the medial surface, but they will also be supplying some of the branches to the inferior surface, that is the orbital part of the inferior surface, as well as a part of the superolateral surface which will be adjacent to the superomedial margin. Now these branches, cortical branches, will be given by A2 and A3 segment. Some of them are unnamed branches, but the named branches include orbital branch, which will supply the inferior surface; frontopolar branch, which will be supplying the frontal pole area; callosomarginal branch, which will be going along the cingulate gyrus, supplying the paracentral lobule as well as medial frontal gyrus, including part of the cingulate gyrus; and the rest of the artery itself continues as the pericallosal artery, which will be going immediately above the corpus callosum. So what is the area of its distribution? It supplies the motor and sensory area of lower limb because it supplies not only paracentral lobule, it will also be supplying part of the area on the superolateral surface adjacent, which will be representing the leg region, the thigh region. So the entire lower limbs, both motor and sensory distribution, will be done by the anterior cerebral artery. It will be supplying internal capsule through its central branches. It will be supplying corpus callosum through its pericallosal branch, and the central branches will also supply corpus striatum. Now coming to the middle cerebral artery, again it's a branch of internal carotid artery. The branch arises on the inferior surface. It turns laterally. It will enter the stem of the lateral sulcus, continues first on the surface of the insular cortex, then exits the stem of the lateral sulcus to come to the superolateral surface. That is where it will continue with the rest of its course. So again, based upon its course, it is divided into 4 segments. M1 segment, which is the sphenoid, also known as sphenoidal segment. Now that is from the point of its origin till the artery bifurcates. M2 segment is that part of the artery which will be in relation to the insular cortex. This will still be within the sylvian fissure. This second part is also known as insular segment. M3 segment, again within the lateral sulcus itself, stem of the lateral sulcus, but now it is coming towards the superolateral surface where the artery is exiting from the stem of the lateral sulcus. This segment is known as operator segment. And M4 is that portion of the artery or its main branches which are seen on the superolateral surface. Now coming to its branches, again the branches are divided into central branch and the cortical branch. The central branches arise from the M1 segment. They include mainly lateral striate branches, or otherwise known as lenticulostriate branches, of which, as I said, one of them is the largest one, known as Charcot's artery, also known as artery of cerebral hemorrhage. This is one of the artery which is commonly having a hemorrhage due to bursting of an aneurysm, and that will result in the stroke, which usually involves internal capsule structures. Now coming to the other branches, few of the central branches will also be named as medial striate branches. Now coming to the cortical branches, from the stem it gives frontobasal branch. These are the central branches. From the stem it will give the frontobasal branch, which will be supplying the posterior part of the orbital surface of the orbital aspect of the inferior surface. Then it will also give anterior temporal branch, which will be basically supplying the temporal pole. Now, when it reaches the surface, it will divide into two divisions, the upper division and the lower division. From the upper division, it will give prefrontal branch. As the name suggests, it will be supplying the prefrontal cortex. Precentral branch, which will be going along the precentral sulcus, supplying the area adjacent to it. Central branch, again going along the central sulcus and supplying the area adjacent to it on either side. Postcentral branch, again as the name suggests, go along the postcentral sulcus. And finally, the parietal branch. The lower division will give middle temporal branch, temporo-occipital branch, and continues as the angular branch. Now coming to the area it supplies, or the area of distribution, it supplies all motor and somatosensory areas except that area which supplies or which is representing the lower limb. It also includes the functional areas which will be controlling the auditory function, speech areas, visual association areas, and the insular cortex. Coming to the posterior cerebral artery. Now, posterior cerebral artery is a branch of basilar artery. As you noted, both anterior and middle cerebral arteries, they are branches of internal carotid artery, whereas posterior cerebral artery is a branch of basilar artery. Now, this is the terminal branch of basilar artery. It takes origin on the inferior surface. Courses, first it will go around related to the inferior surface, and then it will reach on to the medial surface of the cerebrum. Again, based upon its course, it is divided into three segments. The P1 segment is from its origin till such point where it joins with the posterior communicating artery. P2 segment is from the point of junction with the posterior communicating artery till the artery reaches the calcarine sulcus. And P3 segment is that part of the artery which is within the calcarine sulcus. Now coming to the branches, again the branches are divided into central branches and the cortical branches. Central branches arise from P1 segment. They include both thalamoperforate and thalamogeniculate branches. Now thalamogeniculate branch, actually they will arise from the P2 segment beginning. Now coming to the cortical branches, from the stem, one of the artery which arises is the posterior choroidal artery, which is not shown here. The rest of the artery divides into two divisions, lateral division and medial division. The lateral division gives anterior and posterior temporal branches as well as occipitotemporal artery, which will run backwards to supply the posterior part of the tentorial aspect of inferior surface. Now coming to the medial division, it will give a callosal branch. It will give a parieto-occipital branch which will be going along the parieto-occipital sulcus, and the rest of the artery continues as calcarine branch along the calcarine sulcus. Now coming to the area of distribution, it supplies occipital and temporal lobes. It will supply the splenium part of the corpus callosum. It will also supply diencephalon and midbrain. Now coming to the cerebrovascular accidents or CVA. Now, these are actually the third leading cause of death in human beings. One of the common term we use is stroke. That is, stroke is any neurological deficit which lasts beyond 24 hours. And this neurological deficit is due to some vascular reason. There is another term known as transient ischemic attack. Now, this is again a neurological deficit due to some vascular involvement, but here the deficit will not go beyond 24 hours. Now, strokes are classified as hemorrhagic strokes, which can be because of the hemorrhage within the parenchyma of the brain, or it can be hemorrhage within the subarachnoid space, or they are classified as ischemic strokes, wherein the ischemia could be because of the involvement of a large vessel due to a thrombosis or embolism, or it could be because of an involvement of small vessel. Now, risk factors for the stroke are commonly diabetes and hypertension. That's why it is seen most commonly in the elderly people. And most commonly affected artery involved in the cerebrovascular accident is the middle cerebral artery. Now, let us find out what are the effects of lesion to individual arteries. if there is lesion to anterior cerebral artery. Now what will be the effect? First let us see this area which is marked in red color. This is the area which is supplied by anterior cerebral artery. So what are the functional areas we know that it has here? Firstly, it has prefrontal cortex, it has the paracentral lobule, it has a supplementary motor area, it has corpus callosum, at least to name a few. Okay, the paracentral lobule, the area which is marked here, as well as the area which is shown on the superolateral surface, they will be governing the leg region. If you see the superolateral surface, it also includes upper part of the premotor area as well. So if there is lesion to anterior cerebral artery, these are the functions which will be affected. So complete lesion to the trunk of the anterior cerebral artery is relatively rare. More often it will be lesion to one of the branches. If there is lesion to orbital branch or frontopolar branch, then there will be apathy and loss of memory because of involvement of prefrontal cortex. If there is involvement of callosomarginal branch, that will result in weakness in the contralateral lower limb, urinary incontinence, akinesia in mutism. This is because of the involvement of paracentral lobule, that is weakness in the contralateral limb, and urinary incontinence is because of the paracentral lobule. Akinesia in mutism will be because of the involvement of supplementary motor area. And then we have pericallosal branch involvement that will result in idiomotor apraxia, that is the patient will not be able to perform a learned movement, and tactile anomia on the left side, especially when he is holding some object in the left side and he wants to name it, he won't be able to because the left side holding is transferred to the right side hemisphere. From there it has to be transferred to the left side hemisphere for it to be vocalized, because speech areas are on the left side. That is not happening because of the involvement of corpus callosum here. So these are the effects of lesion to the anterior cerebral artery. Now coming to lesion to the middle cerebral artery. So this is the area which is going to be involved, the area shown in yellow color. So let us identify what are the functional areas here. We have primary motor area, we have primary sensory area, we have Broca's speech area, we have Wernicke's speech area. We can also include the arcuate fasciculus which connect these two speech areas. We have auditory areas, we have visual association or visual areas, and we have the frontal eye field. So effect will be involving all these. It also has the temporal pole. So what will be the effects? Because of the motor area involvement, there will be contralateral hemiparesis. Although the area predominantly involves trunk and the upper limbs, including the head region, that is corticonuclear fibers will also be involved. Lower limb will not be spared for a simple reason that although the lower limb region is supplied by anterior cerebral artery, as the fibers descend from this region in the coronary radiata, that area will be supplied by middle cerebral artery. So it will also include lower limb region. Similarly, there is contralateral cortical sensory loss, asteriognosis and hemi-neglect because of the involvement of superior and inferior parietal lobules. Then there is ipsilateral deviation of eyes, that is because of the involvement of frontal eye field of the side. We have talked about the frontal eye field earlier. It is involved in contralateral voluntary saccade. When that area is involved, the opposite frontal eye field will take over. That will result in deviation of the eye to the side of the lesion. There is going to be other eye defects will be homonymous hemianopia because of the involvement of visual areas, or it can be just upper quadrant anopia because of the involvement of only Mayer's loop of fibers. Then we have, because of the involvement of speech areas, Broca's area is involved, Wernicke's area is involved, as well as the arcuate fasciculus is involved. So that will result in global aphasia if the involvement is to the middle cerebral artery supplying the dominant hemisphere. If it is middle cerebral artery supplying the non-dominant hemisphere, then the patient will present with eprosodia. That is, patient will not be able to pay attention to nuances or the cadence of the voice. Then there will be, because of the involvement of central branches, that is internal capsule will be involved here, plus the corticopontocerebellar fibers will be involved. That will result in hemiparesis, hemisensory loss, and as well as ataxia. All of them will be on the same side, that is on the contralateral side. And then the main way to differentiate this from the cortical lesion will be, there will not be aphasia. There may be dysarthria dysarthria will be present because of the involvement of corticonuclear fibers, but aphasia, that is language dysfunction, will not be present in case of involvement of internal capsule. Now coming to the lesion to the posterior cerebral artery. So this is the area supplied by posterior cerebral artery. So what are the areas here? Splenium of the corpus callosum. Around the calcarine sulcus, we have both primary as well as the secondary and para and peristriate areas, second and third and fourth and fifth visual areas as well. And we have the temporal lobe involvement that includes hippocampal formation as well as parahippocampal gyrus, and more laterally the fusiform gyrus, which is the area for recognizing the familiar faces. So involvement of these structures will result in, like, we know that posterior cerebral artery will also supply the midbrain. So if those branches are involved, the patient may present with Weber's syndrome, that is alternating hemiplasia, hemiparesis, which includes ipsilateral oculomotor nerve involvement and contralateral hemiplasia or hemiparesis. The other possible involvements will be involving the thalamo-geniculate branches. These will be supplying the ventral posterior nucleus of the thalamus and the lateral geniculate branches, lateral geniculate body. So these two will result in contralateral sensory loss and homonymous hemianopia. The branch supplying the corpus callosum, if that is involved, the patient will have alexia for material in the left-sided visual field. Again, same reason. The patient, whatever he is seeing in the left half of the visual field, that will reach his right-sided visual cortex. Now this information has to pass to the left side for it to be verbalized, but or read. But for that to happen, the corpus callosum has to be intact. But because of the involvement of splenium, the patient will have alexia for the left half of this, whatever will be present in the left half of the visual field. The cortical branches to occipital lobe, that involvement of those will result in homonymous hemianopia. So these will be the branches which will be supplying the visual areas. There may be macular sparing. As we have said already, macular sparing could be because of the dual blood supply, although posterior cerebral artery may be involved. Because the middle cerebral artery is still intact, macula can be spared. The second reason why macula can be spared is because of the dual representation. That is, although the left side, one hemisphere is involved, the other side artery being normal, other hemisphere will be normal. Macula gets represented on bilaterally, but the part of the macula, left half on the left side and right half of the right side. But still, because it's a very tiny area, the other side cortex being normal, it will take over the function. The other possibility is just the third reason which is proposed is the patient just slight adjustment to the eye so that the picture gets transferred to the opposite cortex. So although his one cortex is lost, he cannot make out the macular function lost on that half of the macula, simply because he shifts the head transversely by a few degrees. The image will shift onto the contralateral cortex. So any one of these reasons will make sure that macular area is spared, but rest of the visual field will have the blindness. And cortical branches to the temporal lobe, that is the area supplying the areas involving hippocampal formation, parahippocampal gyrus and the fusiform gyrus, that will result in the patient having amnesia, especially the anterograde amnesia, and prosopagnosia, that is inability to identify familiar faces. So strokes are actually one of the commonest features with which the patients will present to you in the clinical side. The knowledge of blood supply to the cerebrum will help you identify which artery is most likely to be involved, even before the patient is taken to next level of investigations. Thank you very much. Hope you enjoyed this video. You can visit this video site for other neuroanatomy videos.